Testing. Hey, this is Kelly. And Dr. Camp, I'm going to talk today about home care of the infant. And this is in your Murray book, and it's on page 462, chapter 23. So this podcast is going to be my lecture of both chapters. We're mainly doing this because we have the newborn sim all day, so we're going to allow you to do the podcast. It's very important you listen to this. It's just like my lecture. Have your notes printed so you can write some notes down with that. So, information the new parents need, and they're going to have questions about their newborn, concerns about the adjustment to parenthood, and they're going to really need some help. If they don't have parents, they're going to need friends. You have to imagine these parents are going to be tired, bringing home this new little baby. And the first baby, it's going to be a little life-altering. Some facilities do a home visit within the first 24 to 72 hours, and RNs do this. It's when they assess and do a lot of teaching. So they're going to need to know physical needs, learning after birth, how to deal with early parenting. If they don't have an extended family, they might need friends to help, or other resources. So the follow-up time is going to be dependent on each individual. If they're a low-risk family, again, this can be done at home or at the first follow-up. If they're high-risk, it needs to be pretty soon. They need to have contact with a nurse, someone to call if they really have questions. So again, you want to see these patients back 24 to 72 hours after discharge, kind of depending on if they're low risk or high risk. And some institutions do home visits. Outpatient visits are a lot more cost effective. They can do telephone counseling, things of that nature. If you're going to go to someone's home, you need to make sure that you also teach them about car seat safety and how they have to have a car seat. There's a lot of programs out there where they can get a free car seat if they need it. And then your book goes into talking about problems. So we're going to spend a few minutes on this, and then I'm going to have a video to talk to you about crying. Crying is a very common problem. Okay, so early problems include crying, and for you students that have children, you kind of experience this, but babies do cry. Their crying peaks about 6 weeks of age. They cry about 3 hours a day, and it's usually because one of a few things. They're hungry, they're tired, they might be wet or soiled, they might need to burp. And also overstimulation. Sometimes we don't think about that, but babies can get overstimulated and tired. Ways you can help when they're crying, obviously, is to see if they're hungry, check if they're wet or soiled, see if they need to burp, and swaddling is a really good thing to do for a crying baby. So you swaddle them. I'm fixing to show you a video of that for non-mothers or maybe people that didn't even ever swaddle. And white noise. Many parents will say, my kids loved it in the laundry room, or the sound of, something running a fan. Colic, on the other hand, is when a baby cries for more than 3 hours. Usually occurs late in the afternoon, early evening. It's almost like sundowning for babies. It usually occurs more than 3 days a week. About 10 to 20% of these babies will be colic, and it usually occurs up to 6 months of age. They used to associate it a lot too in premature babies, but there's really no etiology that causes colic. It's unknown. Some science and evidence says it could be related to gas. So because of that, when we're educating our patients, first of all, you want to talk to your clients about their feelings. You know, this is going to stress them out. A crying baby is very stressful. They might need help or resources. They need to know it's okay to let a baby cry. Okay, a baby is not going to, it's not neglectful or hurtful to let a baby cry, and they may need help. If you're sleep deprived and tired, the last thing we want these parents to do is shake the baby, and that's clearly out of frustration. We want to teach them they can walk away, they can put the baby in a safe place, walk away, get some help, because a head injury from shaken baby syndrome is the #1 cause of death in infants, and 25% of the deaths in infants is related to this. So we want to make sure that they know the 5 S's, which are swing the baby, swaddle the baby, shush the baby, which is an actual shh, 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 rocking with the baby, a pacifier, the sucking, and putting him in a side position actually can help. Other things that can help are going to be a chamomile tea, which is a little, check with the healthcare provider on that. I've never heard of giving an infant chamomile tea, but you can give them some methazone as a gas medication, a quiet environment, switch people. I know when my kids would get kind of colicky or upset, my husband could take over and get them to quiet down quickly. Sorry about that. Car ride. A lot of parents buckle them in, take them for a car ride. Again, white noise. Heat. A warm blanket on their belly. My one child loved pacifiers, so give them a pass heat. And massage. So those are some things. Sleep usually occurs. They usually sleep about 16 to 17 hours a day. Must put them on their back, okay? We do not put them on their stomachs anymore or even their sides. Why? You guys should know that for SIDS. Sudden infant death syndrome. No pillows, no even bumpers at this age, no dolls, nothing like that. They need a firm mattress on their back. And by the time they're about 12 weeks old, some of them will sleep through the night, about 5 hours. And by the time they're a year, typically they're going to sleep a 10-hour night and have 2 naps, a morning nap and an afternoon nap. So these are things that you'll have to talk to your clients about. Working mothers, they're going to have a little bit more issue because, first of all, they're not with their baby all day. That already kind of puts them at a disadvantage and makes them feel guilty. And then they're tired from working. So those are conversations you may have to have. They also need help. And they ought not feel guilty. Adoptive patients or adoptive parents, are the same as us, right? Just because they didn't birth that baby, they still have the same love that they would for that child as if it's their own. So, common questions and concerns are dressing the baby. They should always be dressed warmly. When they're real little, you want to have a hat. Even in the summer, a blanket, a little onesie. I always kept mine in pajamas all the time because their metabolism is much higher and they need to be warm. They are going to go to the bathroom a lot. It's not going to be a form stool. It's going to be, depending on what they're eating, if it's breast milk, it's going to be more of a watery, yellow, mushy. And even if they're taking a formula, it's going to be that way. Smoking, why don't we want them to smoke, right? Secondhand smoke can cause all kinds of problems with them. They'll cause problems with weight gain and their eating. Eyes, they may get mucus, that's normal. And strabismus is normal. That's where one eye moves. Like if you're staring at the baby, you might actually have one eye briefly wander, and that should improve over the first 12 weeks of their life. Bathing is typically done, and I'm going to show you a video in that, as well as nails. Let me see if I can pull that video up.
I'm Rosie Pope, founder of Rosie Pope Maternity and Mom Prep. You're about to meet Rosalie Hunt, a labor and delivery nurse that's assisted in literally thousands of births, including the delivery of my son. She's going to be teaching us Infant Care 101, to include adding a few drops of baby soap on that. I'm Rosie Pope, founder of Rosie Pope Maternity and Mom Prep. You're about to meet Rosalie Hunt, a labor and delivery nurse that's assisted in literally thousands of births, including the delivery of my son. She's going to be teaching us Infant Care 101, to include bathing, diapering, and swaddling your baby. Hi, welcome to Mom Prep. I'm Rosalie Hunt, Mom Prep expert, labor and delivery nurse, and childbirth educator. Today we're going to be going over Newborn Care 101. So we'll start with the bath, then go on to diapering and swaddling. We're going to start with the sponge bath. We're going to do this bath until the umbilical cord stump falls off, so usually around day 10. Preparation is key for the bath and for diapering. Make sure you have everything you need with you. So you're going to have 2 washcloths. One's going to be a soapy washcloth and one's going to be to rinse. You're going to have your baby shampoo, a bowl of water, a towel, and then a towel for drying the baby off afterwards. So I usually start with the head, go from head to toe, and bottom last. I start with the hair. Babies like to have their hair washed, but they don't really like being exposed for the whole bath. So we'll start with the hair and the face. You can either do this part under the sink, or you can do it with a bowl of warm water. So you take a little water, splash it on the baby's head, and then a few drops of baby shampoo. You can rinse, and then, there we go, rinse off. And then from there, we're going to wash the baby's face. So a baby doesn't need a bath every day, but it's good to wash their face, around under their neck, behind their ears every day. Just dip a washcloth in a little warm water, no soap. Wash their face, under their neck, and behind their ears. So you want to do that every day. And then we'll proceed on to the bath. So we'll lay our baby down. And this sometimes can be a 2-person job, especially the first few times you give a bath. You may feel like you need an extra set of hands. So we'll start with the soapy washcloth. So we'll just take 1 washcloth, dip it in some water, and add a few drops of soap. And then we already did the face and the neck. So we're just going to take from head to toe, just the chest, torso, legs, their back, and their bottom last with soapy washcloth. And then another washcloth, this is just going to be to rinse. So you dip this one in just water, and then rinse their torso, their arms, their legs, and their bottom. Just bring your towel up over your shoulder, and bring baby onto that towel, and dry them off. So that pretty much concludes the sponge bath. Again, this is until the umbilical cord stump falls off. Then after the umbilical cord stump falls off, you can go to the regular tub bath. So I've already pre-filled the tub with about 2 inches of warm water. Again, warm, not hot. And you don't have to fill the tub all the way up, just a little bit of water. Anytime you're giving the baby a bath, you want to make sure that you keep one hand on the baby the whole time, and that you never leave a baby unattended in the bath. So I usually put my hand underneath the baby's neck like this. Then I rinse baby off, a little bit of the warm water. Babies usually really like the bath. And then take 1 washcloth and just rinse their face, wiping their face underneath their neck, behind their ears, working from head to toe and the bottom last again. So from the head, you're going to rinse a little bit of water over the baby's head, just making sure not to go over the baby's face, just towards the back of the head. Add a few drops of baby shampoo, rinse, wash, there you go, and rinse. And then taking your washcloth, adding a few drops of baby soap on that, or baby shampoo, and just washing their torso underneath their arms, down their legs, and around their back, and bottom last. Then you can either take a squirt bottle if you like and kind of rinse the baby off, or you can use a cup. Then you're going to take your towel, bring it up over your shoulder, and lift baby up out of the tub onto the towel, drying the baby off. And that finishes our tub bath. So now we're going to go into diapering and swaddling the baby. So to check a baby's diaper and to change it, say, looks like the baby had a poop. So you want to wipe from front to back. Just with this diaper, I think it's a good idea. You can use the top part of this diaper and wipe from front to back. Kind of contain that poopy diaper inside. That way you have a clean surface to work on. Always make sure you have your extra diapers handy and your wipes, because inevitably the baby is peeing and pooping while you're changing them. You wipe from front to back. That's really important, especially with baby girls. Front to back. There we go. And then we'll bring our new diaper, slide it under them with the tabs in the back, and then tuck the top part down. Keeping track of how often the baby's going to the bathroom is a really good idea. It's a good thing to tell how much food the baby's getting. They're probably going to at least have one dirty diaper in 24 hours. They're probably going to have lots more than that, but it's good to make sure they at least have one in 24 hours. For wet diapers, it goes by day of life. So day 1, in the first 24 hours, they have 1 wet diaper. Day 2, 2, day 3, 3, day 4, 4, day 5, 5, and day 6, 6 or more wet diapers a day. After day 6, they should just continue to have 6 or more wet diapers a day. If the baby hasn't had a pee or hasn't had a poop in 24 hours, that's something to call your pediatrician about. If the baby does start to have a diaper rash, you can use diaper rash cream. The best way to prevent a diaper rash is changing the diaper frequently. If you notice that the rash is spreading quickly or oozing, that's something to call your pediatrician about as well. So now our baby's all diapered and good to go, and we're going to show swaddling. Babies love being swaddled. You want to have your swaddle blanket. I usually just take a regular swaddle cloth and fold the top part down. So it's like a diamond with the top folded down, so you have 2 sides and a bottom corner. I'm going to lay that down and bring baby on top. And align the baby's shoulders with the top fold in the blanket. Usually bring the baby's arms together in the front. And then bring one side up over baby and tuck it under their back and their bottom. Babies like to be really snugly wrapped. Then you take the bottom corner, bring it up and underneath their shoulder. And then the other side comes up and around underneath the baby. So this creates a womb-like environment, makes them feel secure and snug. So now your newborn is happy and swaddled. And that's the end of Newborn 101. Now you know how to bathe the baby, diaper, and swaddle them.
Okay. So some common concerns are going to be, again, sucking needs. Babies, that's one of the things they do. They might need a pacifier. Some parents that allow their child to suck their finger. I mean, it's just a preference, I guess, in certain cultures and families, as long as their finger's clean, right? Teething, that occurs, somebody have to answer that, I wish I was in class. Teething occurs a little bit later. I breastfed both my children. Typically, if you're breastfeeding them, they really don't get teeth until they're about 9 months to a year old. But there's every child's different. So if they start teething, little massaging of their gums will help, and you can buy some Ambisol or something like that to put on their gums. Common problems are like diaper rash. I call it dermatitis. It happens a lot because, of course, the baby sleeps all night and they're going to get urine on their diaper or feces, and so it becomes irritated and red. Basically, that's why a child needs, or an infant needs, a bath, and it doesn't have to be a long bath or soaking bath. Just a little bit of a fragrance-free soap and rinsing, patting dry, and then a barrier cream. When I say barrier cream, like a zinc oxide, so Desitin, something like that. If it gets really bad, you can also apply an antifungal underneath, like a ketoconazole, and then the barrier cream on top. Babies can get baby acne or miliaria, and that's just like little bitty bumps. It looks like acne, a little pus pocket. It's from prickly heat. It's normal. Just bathing them, it'll get better. Seborrhea is another thing they'll get. The cradle cap or cheesy-like material on the top of the scalp, and that's usually controlled with a baby shampoo, a comb, and then applying baby oil or mineral oil on the scalp. If it gets really bad, again, per the doctor's instructions, you can put a little bit of ketoconazole shampoo there, leave it on for 5 to 10 minutes, and then rinse it off. But again, they really don't need to be doing that unless they contact a physician first, or a dermatologist, or whoever they have the baby see. So feeding concerns, regurgitation is really common. Everything on a baby's new. If they eat too much, they can spit up and they can vomit, and sometimes it can look like an entire feeding. So the good thing to do is to burp them often after several ounces. Make sure they have a good seal. You're going to be doing a lot of breastfeeding teaching, and so when they're when they're latching that baby onto the breast, you got to make sure that the baby's got a good seal, not getting any extra air. Same with the bottle, and then you can burp them often. The other thing is sometimes you want to enlarge with a sterile needle the hole of the nipple if you're bottle feeding them, because sometimes they're sucking so hard that they're not getting enough formula or even breast milk. Upright feeding can help. Again, burping them very often. And if they have continual projectile vomiting, you need to let some healthcare provider know, because that could be indicative of pyloric stenosis. But again, they're not going to have any weight gain, and when you have a newborn, you're going to go see your doctor very often. I can't remember when I first saw mine, but I want to say you take them in like 2 to 3 days after their birth, because they want that weight, because their weight should be doubling. Okay, so one thing I didn't mention under smoking is it's a #1 cause for SIDS, okay? So why do we want them not to smoke? It's for sudden infant death syndrome, SIDS, okay? It can contribute to that and make that baby more at risk. And the other thing I didn't talk about is, weight gain is very important. So the growth chart will be looked at the doctor's office. You want the baby to gain weight, and so the doctor will really be looking at that. And another thing we didn't cover, since we're talking about feeding, is the more hydration and food they take in. If a baby's born with a high bilirubin, which sometimes they are from traumatic birth and other reasons, the more excretion is going to help get that out of their system and hopefully prevent them from needing any kind of phototherapy. And phototherapy is just another pain to deal with when you have a newborn or infant. I had to do that with one of my children. So getting them to poop and pee is going to help excrete that extra bilirubin. Solid food, they're really not going to take any solid food until they're about 4 to 6 months of age. The doctor will typically have you start one product, like maybe sweet potatoes for 5 to 7 days to make sure they do okay. This is to reduce risk of allergy. And then after 5 to 6 days, if they're taking it, not having allergies, they might let you start another one. And typically they're going to tell you to stay with all the orange vegetables and then to process the green vegetables. Then you can add the fruit. And for some reason, if I'm not mistaken, they're always going to want you to start the meat last. And just remember that they should never be on milk. They drink breast milk formula, but no milk until they're over a year of age. And a lot of doctors will also start a baby on rice cereal before they'll start any solid foods. And it'll just be rice cereal mixed with breast milk or formula. And a lot of doctors really want to wait till they're 6 months of age before they do solid food. And it all depends on how well your baby's sleeping and gaining weight. So that's really important. Okay, so again, RN's jobs are really going to be important to focus on teaching, especially when it comes to prenatal and infant care. That's going to be the role of an RN. So if you've been through the baby process, it's going to help, but we don't want you to remember what happened to you. We want you to learn as an RN what to teach other people, okay? So again, don't forget the classes that are available, the resources, how to reduce anxiety for this new mother. And what really helps is kind of knowing the milestones. So just remember that the baby will lose weight in the beginning. It should be regained in about 2 weeks or 14 days. And it's every practitioner is different. I believe most of them have you come in 48, 72 hours after the birth, and some wait 2 weeks because they want to see. If you're dealing with the health department, they typically wait about 2 weeks because that weight should double. By 3 months of age, they should be gaining 1 ounce a day or 2 pounds a month. They grow about inch and a half in a month lengthwise, and their head circumference was going to grow about 2 centimeters a month. So when you go to the well clinic, they're going to weigh them, they're going to measure their length, they're going to measure their head circumference, they're doing an exam on them, just make sure, and then they'll put everything on that growth chart. Now I think I have given you guys this. I think I gave you a sample growth chart. Here's a sample growth chart, and it's where they're going to measure their height and weight. And so these are also called well child checks. If you work in a doctor's office now, you're familiar with this. If you plan to work for one in the future, you'll see this as well. Usually the well checks are included in the insurance, and most insurances it costs nothing. And they generally occur the first month, second month, 4th, 6th, 9th, 12th month. And also this is when they're going to be given the immunizations. And I know I gave you an immunization chart, so make sure you look at that. Usually the first shots are at 2 months, 2 and 4 and 6. Fontanelles will close at 2 months, and the head control really starts to develop at 3 months. And usually if they have good head control at 3 months or 12 weeks, that's when you can put them in the prone position. Is it prone position? Yeah. Face down on the bed, and it's safe. So in your book, don't forget to really go over SIDS. It's on page 474, How to Prevent SIDS. There's a box there. You really need to go over that, okay? That's typically something you'll see in NCLEX. The last part of the chapter is who and when to call a practitioner, recognizing the signs of a sick infant, and also accident prevention. We just went over this part. So infant safety, they must be in a car seat, and the car seat must be reversed, reverse riding. I believe they have to do reverse riding. If I was in class, I'd have someone look it up. It's for a while, until they weigh, let's just look it up. It's until they weigh a certain, I want to say 20 pounds. Reverse. That's a good source or not. Age 2. I don't know about that. By the American Academy of Pediatrics. Rear facing until 2. A booster until they're 8. So maybe review that if we were in class, we'd talk about that. Other safety concerns are going to be when they're babies, their head's heavier, so want to protect their head and make sure that when they start crawling and ambulating, to keep objects out of their path, because they put everything in their mouth. The second most common thing happening with babies is swallowing and choking. So you got to child-proof the house. They can't be around water, because an inch of water they could literally drown in it. So things like that. Plug-ins have to be covered. Most people put something over the toilet so they can't get in it, even in the cabinet so they can't open a cabinet. You have to teach your clients all this. So accident prevention, we talked about well checks. Illnesses, we talked about immunizations. Illness, so recognizing the signs, you guys should know this pretty well. Temperature over 100.4, vomiting more than twice a day, diarrhea over more than normal, sores or rashes that are unusual, not sleeping or eating, not gaining weight, a cough, drainage from the ear. And so there's box 23-3 and box 23-4 that you need to review. So this ends the first chapter. At this point, I'd like you to take a break, 5 or 10 minutes, and then I'm going to do the second chapter of this lecture. Okay, hopefully you got back from your break. I don't know if y'all can see me or not. So families with special needs, and this chapter isn't exactly what you think it is. It's more about adolescent pregnancies, teenagers, and 10,010, the lowest rate ever recorded for births of women 15 to 19 was in the United States. That statistic's actually a lot lower now, thank goodness. So factors associated with teenage pregnancy, some want to feel wanted, and they feel like if they have sex with this boy, he's going to love them, and having a baby is going to make them a perfect family. So I think that's what young people think. Other reasons are accidents. They don't know about birth control. They don't understand the process of conception. So they have that one night of fun and they're pregnant. So they don't have knowledge of condoms and prevention of pregnancy with birth control pills. They don't know that if you take an antibiotic on a birth control pill that it's inactive, it's ineffective, and you can get pregnant. So a lot of things, they don't think that getting pregnant can happen to them. They have this whole concept of it's never going to happen to me, okay? They date older guys. There's just a lot of reasons behind it. I think sex education is super important in the schools. I'm an advocate for it, but we live in the Bible Belt, and we live in an area where very few agree with me, especially parents. I talk openly with my children about it. Heck, I scare them to death about it. Show them pictures of things that could be growing off their body. So, if they have had sex education, the pressures to have sex are going to be lower because they know what might happen. So that's where education's key. And it's really important that they have some type of sex education. Then we as healthcare providers need options for these young women if they become pregnant or an unwanted pregnancy. Options they can have. Of course, there is abortion, there is pregnancy with adoption, or there is to keep the baby. So again, we have to put on our nursing face and forget our personal opinions, and that's sometimes really hard to do, but we have to do that. We can't judge people, but these young teenagers need to know how to seek, where to seek for their options. So also socioeconomic's a big deal. They may not have this covered on medical insurance. They may not have medical insurance. There's always the health department. There's other avenues. And if a female decides to adopt, sometimes the adoptive family will take over the costs associated with the pregnancy. Because our job is to really protect that baby, right? And it talks about implications for maternal health. Most pregnant teens don't have complications, but some do, so read that in here. Prenatal care is very important, not only for older people, but for teenagers. So they need to know about prenatal care and the fetal health as well. They need to include the father, especially if he's involved and expecting. Again, it may be a little awkward situation, but we need to put our judgment aside on that. And they need to be ready to be parents if they decide that they're going to do this. There's been a lot of families started at a young age, and everything's turned out fantastic. So the more support we can give them, the better. So the nursing process and how it applies to a pregnant teenager, we always start with assessment, and you're going to determine the degree of the participation by the father. How much family support does this young lady have? Cognitively, can they take care of a baby? So you need to check on that. Knowledge, again, a family assessment. Their diagnoses are going to be related to nutrition, making sure they're getting enough food, making sure they have their immunizations, like a regular pregnant person, really, right? So on the gamut of that we already discussed. Our expected outcomes are going to be that mom gets prenatal care, that she takes good care of that baby and herself, and she has a healthy baby, right? And that she can voice her concerns and expectations. Interventions are going to be to eliminate barriers to health care, so we might have to find them alternatives to get health care. Teach and help them learn, counseling, family support, referrals. And then the evaluation is going to be, making sure that we respond quickly and that we're there to teach her basic care, the development, just like we talked about in the other video. Delayed pregnancy. I don't really know if the book talks much about delayed pregnancy. Let me see if I can find it here. Delayed pregnancy. I guess this is for older people. I guess I'd be in that category. One positive thing with delayed pregnancy is you've had your fun, you know what you want, you might be a little bit more financially secure, maybe not, but it's a more mature decision. And I see this a lot with people that adopt. They're in their late 30s, early 40s, both have good jobs, and they want to adopt a baby. So that's going to help with the stress. You've got a secure relationship. So the only thing you really have to worry about, the disadvantage, is you might have trouble getting pregnant if you wait too late, and because as we get older, our hormones decrease. And then other things that may happen is you may be at risk for some fraternal complications. So a lot of physicians, if they have a mother, I believe over the age of 35, they recommend an amniocentesis to make sure that the baby's going to be healthy. And as you get older, you may have comorbidities like diabetes and things like that. So you have to think about that. You may not be as agile either, but I did fine. I think most mothers in their 30s and 40s do fine. You're actually seeing mothers have babies in their age of 50. And So that's not very uncommon. Okay, it says here, many couples find it difficult to wait for results, will often elicit free expression of their feelings. Follow-up questions such as what concerns you most may reveal anxiety about the procedure itself and how the possible effects of the procedure on the fetus. Simply acknowledge that this is a stressful time and keep the couple, help the couple cope with their emotions, and that's under facilitating expression of emotion. So the next part of this chapter is substance abuse. I'm not going to go into great detail. You guys can read that. It's on page 486. If you look in table 24-2, it even starts with caffeine. Okay, so caffeine is a drug. It talks about that and what it can do on the mama and on the baby. It goes through tobacco, alcohol, crack, opiates, antidepressants. Basically, if you're pregnant, you can't take hardly anything. But it talks about the effects of that. Make sure you read it and make sure you have a general knowledge of how it's going to affect the mom and the baby. Tobacco typically is going to cause prematurity, about 30% of the time. And also can cause asthma, colic. Alcohol can cause fetal alcohol syndrome. Marijuana can also cause problems with sleep disturbances. It can cause increased risk for carbon monoxide in the blood. Cocaine can cause irritability, lethargy in the baby, and the list goes on and on and on. So read through that. I bet Miss Kathy can tell you about a lot of babies she's seen born on drugs. Again, here's a nursing process. Congenital abnormalities. One thing you can teach and try to get your clients to do is prenatal care again. Because if you go in it 100% and you know what to expect, the grief and mourning is going to be a lot less. An example is a Down syndrome baby. So, though it happens to moms, it can happen a lot in teenagers actually, teenagers and older women. So if you have a young teenager or a woman over 35, I recommend ruling out Down syndrome. If you find out you have a Down syndrome baby, I had amniocentesis. So why? A, if you have a Down syndrome baby, you know it, and you can get the resources and you can get the help you need so that when that baby comes, A, it's not a shock, and B, you have help. Other reasons for the amnio is maybe you'd want to terminate the pregnancy. So a mom with her first baby coming out as a Down syndrome without knowing it would be very, very difficult to deal with. And that's the best example I can give on that. So here's a case study, and I think what I want to do with this case study is I'm going to give you all a little assignment. I only want this podcast to be about an hour. I know you're probably bored to death. So I think I'm going to let you do this case study on your own. You have Miss Tucker and her husband. They've experienced a perfect planned pregnancy. Miss Tucker is 28 years old. She's been pregnant once and had one baby. So that's Grava 1, Para 1. And she begins prenatal care at 8 weeks of gestation, and her lab has been normal. Ultrasound shows no abnormalities. Her pregnancy weight gain is 37 pounds. She's admitted last evening at 2300. And at 7 a.m. you assume care of the family. She's complete and laboring with an epidural. At 9:08, she gives birth to an infant boy with APGAR of 9 out of 9. She's placed directly in Miss Tucker's abdomen, and her and her husband begin to meet their son. And while counting his fingers and toes, they notice something unusual about the shape of his legs and ask the physician to look. The physician notes that The baby has club feet, and so Mr. Tucker becomes angry and yells that they had an ultrasound and you said everything was perfect. How could this happen? So what do you think you should say? And the pediatrician confirms the infant has club feet and asks the orthopedist to see the baby. And what are nursing considerations you can do in the postpartum period? So I think what I'd like y'all to do is write a little something about this. What would you say to that family? How would you console them? And what are the nursing considerations during the postpartum period? And I will post an assignment that'll pop up after this podcast, and I'll give you guys the week to do this. I would like it to be at least 200 words, good punctuation, good grammar, and if you reference the book, you need to put it in a reference, or if you reference another source, don't forget to cite your references. This will be equal to a pre-lecture quiz, so it'll be worth 5 points. And since we don't have clickers tonight, I'll give you an additional attendance point if you did in fact watch the podcast and do the assignment. So next slide, just talk about pregnancy loss. So read over that. I can't imagine. I'm sure that would be like a death, right? So it's going to be pretty a pretty hard time for that mom and dad. Don't forget your nursing process during this. Your ADPI. Adoption is a great alternative for folks that cannot get pregnant. Need to know a little bit about partner violence and your role in this, how to recognize it, and how to help this mom, or I guess it could be a dad, but more usually it's a mom, on how to protect themselves, protect the baby, and know the signs and symptoms of that. Again, here's a nursing process for battered women. So read over that. That is on page 499. And there's also a good read on myths and realities on violence on women on table 24-3. So we'll do this real quick. A woman is admitted to recent cocaine use and active labor. Her vital signs are 88, her respirations are 20 and irregular. Her blood pressure is 160/90. She seems lethargic and is sweating profusely. The nurse should position her on her right side, elevate the head of the bed 90 degrees, maintain the side rails up at all times, keep the overhead lights on for accurate observation. Answer is C, maintain the rails up at all time. And here is the rationale. They are at risk for hypertension, crisis, and seizures, so keeping the side rails up is safety of the client. I believe that's it. Don't forget your other resources for these chapters, like this resource right here. This is under the students section. Session is timed out. So you can go to your portal. I don't know why I can't get this any bigger. You can go to the quiz, NCLEX type style questions. You can continue where you left off. You can begin the quiz. These are going to be very similar to the quiz or the test questions that Miss Kathy prepares for you. I'm sorry I cannot enlarge this. I'm sure if I... So it would behoove you to go through these questions as well.